In this video, we describe the surgical technique of the up the neck view during hip arthroscopy for cam resection in the setting of mixed-type femoroacetabular impingement. We will start with a case discussion and conclude with pearls and pitfalls of this technique. We present a 28-year-old female with a 6-month history of left hip pain. She reports that her pain is 6 out of 10 and is exacerbated by physical activity. She reports that her pain is located deep in her groin region and that her symptoms have not improved despite a trial of non-steroidal anti-inflammatory drugs, activity modification, and physical therapy. On physical exam, the patient has no deformity of her left lower extremity and is tender to palpation over the hip flexors and the piriformis. Her range of motion is 90 degrees of flexion, 25 degrees and 40 degrees of internal rotation and external rotation at 90 degrees flexion respectively, 10 degrees of supine extension, and finally 45 degrees of both abduction and adduction. She has 5 out of 5 strength through all muscle groups of her left lower extremity. She has a positive Faber test, subspine impingement, and circumduction clunk. Radiographic assessment in the form of anterior-posterior, done lateral, and false profile radiographs revealed a mixed-type femoroacetabular impingement syndrome. Magnetic resonance imaging with contrast revealed a labral tear. After discussing the treatment options and the risks and benefits, the patient elected to proceed with operative intervention in the form of hip arthroscopy with labral repair, acetabuloplasty, and femoroplasty. Prior to induction of anesthesia, a femoral nerve block is placed in the operative extremity. The patient is then placed in the supine position on a fracture table and undergoes endotracheal intubation for general anesthesia. The patient's operative leg is brought through a full range of motion to assess for hip flexion, abduction, and extension. Fluoroscopy is placed on the non-operative side of the patient. The patient's feet are placed in well-padded traction boots with a postless technique, and all bony prominences are well padded. The perineal post is no longer used because of the potential complications that can arise, including short-term urologic or sexual dysfunction, transient neuropraxia involving the pudendal or sciatic nerves, and soft tissue injury. The patient and all equipment are prepped and draped in a sterile fashion. A sterile marking pen is used to outline the greater trochanter as well as approximate incision sites for portal placement. Attention is first turned to the labrum for repair and acetabuloplasty. Under fluoroscopy, a standard anterolateral arthroscopy portal is created. A modified anterior portal is established using direct visualization from the anterolateral portal. Throughout the entire procedure, a 70-degree arthroscope is used. Capsulotomy is performed, followed by diagnostic arthroscopy to evaluate the integrity of the labrum and chondral surfaces. The labrum is isolated from the proximal capsule, and a plane is developed to expose the acetabular rim. With a shaver, an acetabuloplasty is performed as needed until a bed of bleeding bone is exposed for labral healing. The labrum is repaired with an anchor and suture construct. The hip is then reduced and the suction seal is evaluated. Attention is then turned towards the femoral neck for cam resection. An internal T-capsulotomy is performed with particular care to protect the circumflex femoral arteries, and retention sutures are placed to optimize exposure of the cam lesion. Fluoroscopy is used to delineate the articular cartilage margin. Initial resection of the cam is performed with the camera in the anterolateral portal and the shaver in the mid-anterior portal. The 70-degree scope is then rotated 90 degrees to achieve the up-the-neck view, such that the head and neck junction appears horizontally on the arthroscopic view. Using the up-the-neck view, additional imperfections that may not have been visualized on the traditional view can now be visualized. Additional resection is performed until a smooth contour of the femoral head and neck junction is achieved. The capsule is then closed using non-absorbable suture. Compression is applied to allow fluid drainage from the arthroscopic portal sites. The sites are closed and the patient is placed in a hip immobilizer. It is critical not to extend the capsulotomy into the anterior capsule over the iliopsoas in order to allow for adequate retraction of the medial capsule during osteoplasty. Appropriate placement of the more anterior medial retention suture allows for tenting of the medial capsule, which allows for better visualization of the contour medially at the femoral head and neck junction. Differential tensioning of the capsular retention sutures may be required. Increased tensioning allows for access to the medial femoral neck, while decreased tensioning allows for access to the lateral femoral neck. It is important to place the arthroscope proximal to the capsular flap and to use the scope as a retractor to allow for adequate visualization of the femoral neck. Creating an interportal capsulotomy too distally on the neck may limit the ability to retract the distal capsular flap, impairing visualization of the lateral aspect of the resection. Extension of the capsulotomy into the area of the iliopsoas may compromise the ability to suspend the medial aspect of the capsule with this technique. A medial retention suture placed too laterally may not allow for appropriate medial tenting of the capsule with this technique. Partial thickness retention suture placement may not allow for adequate visualization of the mid to distal femoral neck. When used in conjunction with the standard view, the up-the-neck view provides a secondary approach which enables the surgeon to better visualize any imperfections at the head and neck junction. This may reduce the need for revision surgery due to inadequate bony resection. However, no prospective or retrospective studies to date have examined incidents of reoperation when using this technique.